Um, when this is recorded, the chat board is not recorded, but we will be putting this on YouTube. It is the most widely watched webinar of anything we put out. So we get into the question and answer period. If you don't want your name there, then just change your name. Or if it doesn't matter, I just want you to be informed that we are recording it. There are also some disclosures that I want to share. I am not a certified coder or biller. We do have one of those people on this call tonight. Arden Schwenker is our CFO. And if we get into questions where I just not going to answer, I'm going to call on Arden to help us. I have researched the subject matter now for a good 7 years, but I don't claim to be an expert. It's constantly changing. I go into Reddit and type in doctors' attitudes about RVUs about once a month and get all kinds of new stuff that just kind of blows my mind. The information you're going to get tonight is updated information from 23 from articles, research, and examples from our consulting services. And the contracts presented tonight are real and they are redacted for confidentiality. So here's the question. You know, I was in Chicago speaking a few weeks ago, and there was a midwife there wanting to talk more about RVUs, making an extremely high salary and making RVUs right and left, and she was very happy with that. And there are other people who are very challenged by things you're going to learn tonight in relationship to what can happen. So the question is it friend or foe? So when I think about this, still today, and remember I took a deep dive in 21, there is still zero published research discussing RVU compensation for midwifery. Zero. RVUs were designed for physician practice, not advanced practice providers, and that's really important for you to know. Billing incident to split or shared visits complicates RVU tracking and often misclassifies the work. And as of 25, it's only getting more complicated. And here's the big question. If the RVU tracking system does not differentiate by provider type and CPT code, the RVU doesn't care if a PA did it, if an FNP did it, if a CNM did it, if an MFM did it. It's all attributed the same work value. But you can guess we're not paid the same work value, right? So the question of is it friend or foe could be based on the design of the practice, the way that you're attributed RVUs. But I can promise you anybody in the work environment I've ever talked to is never given the same compensation as a physician. So what are the APP metrics that we use out there? What are they and how are they formulated? Well, isn't that a great question, of which I still don't know the answer, but certainly putting a tracking device on the clinician is how some people feel. I think, Rachel, it was you that said they were tracking patient encounters, and the concept of tracking anything means there could be a performance concept tied to that evaluation process, even if there's no dollar attribution to it. So what is a relative value unit? This may be review for some of you, but we're going to go over it pretty quickly anyway. In 92, Medicare changed physician payments. They worked with the American Medical Association, a lot of the specialty groups, and they standardized a fee schedule based on RVUs and what you are familiar with, which is CPT coding. The dollar amount is determined by a mathematical calculation on the physician's work. You notice it does not say provider. The practice expenses and the malpractice insurance of the physician, not of the APP. So the physician work is divided into 4 subcomponents. The time it takes to perform the service, right? A brain surgeon is going to take more time to do surgery than my orthopedic foot surgeon. So complexity is built in there, including the technical skill and the physical effort. So an orthopedic surgeon is going to be paid more than a pediatrician. Are you getting the flow? This one blows my mind, the amount of mental effort and judgment required. Wouldn't you have loved to have been at that table when they were talking about that one? And stress arising from potential risk to the patient from performing the service. So anyway, all of that has numbers attached to it, and that's how RVUs were created. Do RVUs only drive Medicare reimbursement? And the answer is emphatically no. It impacts everything. Virtually every commercial carrier benchmarks its fee schedule to the Medicare fee schedule. So it's a part of every payer plan that's out there, although the commercial plans are higher than typically what Medicare pays. Why is that? Because there's negotiation that goes on with all kinds of things, including the bargaining power of who's negotiating, sort of the market conditions of what's going on, the power of numbers for who's negotiating for the contracts. So RVUs really cross over every patient encounter you're doing, regardless of the payer type. So here's some basics. They're derived from the billing process and assigned again to a CPT code in order to determine reimbursement. The CPT and ICD codes create the full picture of the medical process for the payer. So as you know, the patient arrived with these symptoms as represented by the ICD code, and we perform these procedures represented by the CPT code. And again, RVUs do not change based on the provider rendering the service. It's based on the level of difficulty of the procedure or level of acuity of the patient evaluation by what the CPT code indicates. So the more complex a patient interaction, the more RVUs assigned. I'm going to pause for just a second and let that settle in for you to think about the midwife model of care. Some midwives take care of high risk, high acuity, complex patients, but the majority of midwives in which the databases gather their numbers do not reflect us taking care of highly complex people. This is all going to come in when we talk in a little bit later. So what is the influence of RVUs on your salary or bonus compensation? Most physicians still today, and an increasing number of APP contracts we see, which I would say, I don't know, my team's on, I would say maybe 50% of them talk about RVUs in the contracts, are setting some kind of indicator for a base salary or a base salary plus a bonus compensation that goes beyond the base. They use national directories to determine the RVU numbers by percentiles, and you're going to see examples, by physician types, or we could say APP types in each specialty and each region of the country. And those categories are similar to what the Bureau of Labor Statistics does when you go on there and look at average salary, mean hourly wage. They're trying to mimic MGMA in particular, which is the largest and oldest medical management group in the nation, what BLS does, so that there's sort of this HR feeling that, well, if we're doing it like BLS does, it must be accurate. So they're providing RVU recommendations by threshold and by percentiles for all APPs with very, very limited data on midwives. And this is the problem, as Rachel said, or somebody a minute ago, oftentimes we're just thrown in a pot if there aren't enough. All APPs are the same, therefore all RVs should be measured in the same way, and that's absolutely not true. The other thing that's important to remember is if you are doing patient education, there's really probably not a CPT code or referring people or on the phone or making rounds. And those are often things that are attributed to non-physician providers to make their day go faster. They can bill more, and your time then is not attributed to any kind of billable income. So here is the 5 medical management firms that influence salary data. We've talked to people who have been impacted, especially by the top 2 and bottom 2. Merritt Hawkins was just bought out by AMN Health about a year and a half ago, and they don't tend to consult as much as recruit. They were the largest recruiting company for APPs in the nation. But the other four do a lot of consulting with health systems when they're reevaluating their tiers to decide how RVUs might be or will become the model that the APPs use. So what is the conversion factor, which is as important as the benchmark of the RVU or the number of RVUs that are assigned? The conversion factor is the multiplier that CMS applies to the RVU to calculate the reimbursement. So CMS announced in January a revised conversion factor. It has decreased year after year from $33.28 in 24 to $32.34 in 25, which is almost a 3% cut from last year. And in 1992, when the model began, the conversion factor was $31. In 2008, it was the highest at 38. So let's just sit here for a second and go, if the highest was 38 in 2008, and I'm a doc out there now, and I've been working a long time, and all of a sudden now in 25, my conversion factor is 32.34, how do you think they feel? How much work does it take for them to get the same income they were getting in 2008? Seriously, they're not happy, and they have a reason to not be happy. And they have a reason to want to be competitive. If they've created a certain lifestyle or chosen a place to live that requires an income that they had been getting in the past. So how do you increase your RVUs? It doesn't matter to me who you are. You have to care for more patients. You have to perform more procedures. You have to treat sicker people, and you have to have a higher complexity of care. And overall, that is not associated with most midwifery-led care models. And it probably is with all the other APPs that are revenue-generating care providers. Are there advantages? See, I can see both sides of the coin. Bonus on an equivalent RVU benchmark and conversion factor for all providers. Wouldn't that be nice? But we've never seen that happen. It does encourage the provider to see a higher volume, especially in the midst of a workforce shortage. Go, 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 Leslie. We don't have enough of us. We need to get these patients seen. And oh, by the way, you're going to get more RVUs for it, right? So there's sort of this incentive. It causes competition and a desire to recruit new patients because you're going to get more RVUs. It encourages the provider to be more productive, to see more patients, to perform more evaluations and procedures. These aren't my pros, by the way. These are other people's pros. You're paid on the code submitted, not on the code billed and collected. And accounts receivable is a whole nother conversation that we're going to briefly talk about. But some people would say there's less risk if you're being paid on the actual code submitted versus the wildly efficient or extremely poor talents of your coding and billing service. It's not affected by differences in insurance payments, and it's the same code for any rendering provider. So what are some disadvantages of RVUs? It leads to burnout quickly and people leaving the practice. And you can imagine how that happens just by the sheer need to work harder, faster, competitively. If paid on a sliding scale, it even ramps up the competition more, and you will see a contract redacted that shows that. It pays for none of the non-billable time, which I've already mentioned. It's less likely to refer your patients out because you want to keep them and to compete for new patients. You're paid for the volume of care, not the quality of care. All bundled or global procedures pay less, and we know that in the OB world. Modifiers can create less RVU value. And here's the one, if I had Arden's face in front of me, I'd be watching. Incorrect charting assigned to codes or undercoding will contribute to underperforming. So there's a basic assumption here for our new grads. If you signed a contract for RVU bonus model and nobody's taught you accurate coding and nobody's giving you audits the first, second, third, 6th month to tell you if you're coding correctly or not, you're probably missing out on a lot of RVUs that should be attributed to you. And here's some pitfalls. Who is the RVU assigned to, the billing or the rendering provider? This is a key question we ask our clients when we're talking to them, and it should be one you ask in an interview if it's not clear in the description that they give you. Your work could be attributed to incident 2 billing, and then you're unable to track it because it's attributed to the physician's NPI. So incident 2, which we found out today, Aetna has come out with some wild decision on, is going to make it harder for you to track your RVUs. Most OB services are bundled, which means a lot of your work hours on obstetric prenatal visits in the office is not attributed to RVUs. And everything here listed like triage, care coordination, labor support, shared visits, on-call services, if they're not being billed for or coded for, then you're not getting RVUs. But a lot of these wouldn't get RVUs anyway. They'd be assigned to the global fee. Another key issue we often talk about is the percentage of time in the clinic versus the hospital. It matters. If you're going to be assigned to do primarily obstetric services in the ambulatory side and catching babies, that means you're going to have very few CPT codes you're billing that generate more RVUs. So understanding the balance of that is important. And longer OB visits, which we love, 45 minutes for an OB return, isn't going to make you any money. It's not going to pay you any more in the CPT RVU world. And E&M codes have lower RVUs than CPT. Your coder and biller providing feedback is essential for you to understand if you're in an RVU-based model, if you are doing things correctly. So what about reality? RVU-based compensation is incredibly opaque, which you're going to see in some contracts. Unless you know, which you don't, it's impossible, the payer mix, the procedure, visit, coding, and billing mix, you can't convert RVUs to cash. Somebody there can, somebody is doing that, but it's much more difficult than working on accounts receivable and net revenue. And I'll give you examples here later. RVU trends change the number you can accumulate based on contracted rates for the provider, the patient volume shared between providers, so it's diluted. If we bring on 3 more midwives and it was just Kelly and I, and now there's 5 of us, it dilutes the number each person generates, right? Inaccurate charting is going to make a difference. Payer mix changes. If the blues are out, like they did in Kansas City for Medicare, then you're not going to be coding anything that's going to be recognized in terms of services by that payer. And the protocol on provider ID attached to the wRVU, which basically means what are the billers and coders being told in terms of how to assign those. RVU, the only feedback is how much the provider is generating in charges. There's no way that you're going to understand how much you billed per quarter or per year in this model. Now, my friend Katie Page, who is not on tonight, is a hawk like I am on LinkedIn. And Katie sent me this by typing my name into this urogynecologist LinkedIn page just yesterday. I sent this to Arden. We haven't had a chance to talk about it, but a lot of light bulbs went off for me when I read this. And I think it's important that we read it. In short, female patients are literally worth less money to the U.S. healthcare system when they need GYN surgery than when a man needs an equivalent urologic surgery. If they are worth less money, their surgeries get postponed, canceled, or not even allowed to happen in certain urgent centers because they're not profitable. You need an endometrius excision that takes 4 hours and requires a laparoscopy. An orthopedic surgeon can earn the same amount of money in 30 minutes. So you can see why hospitals would not want to give their surgical time, anesthesia time, and equipment a way to treat gynecologic issues. Oh man, you're just going to get madder because there's a couple more slides. Why? It's baked into the CMS billing codes, which has a cap for all of medicine. Now, Art and I are involved in some conversations that include adding more CPT codes that ACOG is interested in, and this just validates everything we're learning. When the system was put forth in the 1990s with the Social Security Act, the OBGYN was left behind, undervalued, and given a very small portion of the total pie. Since the budget is capped, upping the value requires lowering the value of something else. Make women's health be worth more money while lowering something else? It has never happened, and it never will happen unless the system is changed from within, which we're working on. And this is a group of female OB/GYN specialists that they're blowing my mind. It's just was published online this week. It's not in print yet, but here's some of their findings. For the 55 gender-specific procedures, 75% had lower RVUs on female patients in 2023. RVU procedures on male patients were 30% higher on average. For facility reimbursement, 64% were higher on male patients with a 26% higher reimbursement on average, correlating to an average reimbursement of $75.73 for male procedures. Now, you just heard the RVUs were lowered, right, to like 32 something. Non-facility reimbursement male procedures were reimbursed 20% higher. In 20 years, between 03 and 23, there were no statistically significant improvements in the reimbursement disparities for male versus female procedures, with male procedures consistently having an average RVU of 31 to 34% higher. Anybody want to comment on that? Open your mic and go for it. We have a second. Arden, are you surprised?
Wait, I had to figure out how to unmute myself. No, unfortunately, I'm not surprised, but only because I spend a lot of time studying the CPT codes, and part of the certification was learning that certain specialties, certain procedures have a lot higher weight. And that's why, like in billing and coding school and training for that, they teach cardiology and ortho because they pay the most money, they have the highest RVUs, and they're weighted higher, which I think is crap, for lack of a more professional scientific term.
Oh,
I just got a EOB for a family member, an ER CPT code. The professional fee CPT code was over $4,000.
Mm-hmm.
And all I thought was, I mean, we are the exactly what you're saying here. Like, you know, women are devalued as a whole, and then those of us that care for them, look where we're left.
Well, and the thing, though, to also look at that a lot of people don't is not just what was billed, because you can bill anything you want, but then what was allowed towards that CPT code and eventually paid. But I bet if $4,000 was submitted on a CPT code for global maternity, for example, or a hysterectomy, it's going to pay a heck of a lot less than any other procedure.
yeah.
That took the same amount of time or a lot less time.
It really began to put things in context for me about the why, which when you're not trained as a filler encoder, you don't have the balcony view. And I'm like, oh my gosh, these guys are helping me understand what's going on here. So what are physician attitudes about RVUs? Well, I can tell you they're changing. All over Reddit, if you want to hear nasty words, just go into Reddit and type physician and RVU reimbursement, and you'll get as much as you want to hear. But I decided to keep it a little clean. Yale New Haven Health, this is going on right now. So this is an article probably from the last month. Many physicians are frustrated, and it's impacting the relationship between the OB department and the midwives. Why would that be? Because they haven't been on RVUs before, and all of a sudden they're all competing for the patients that they've traditionally been seeing there. And a quote from the article, a shift to productivity-based pay sparks debate among Yale New Haven physicians, highlighting fears of competition, inefficiencies, and a potential loss of their academic focus, which is something we really haven't talked about. In an academic setting, how might RVUs be negatively impacting the care that's provided? So here's a Medscape 2024 physician RVU report with a little over 1,000 physicians participating. Again, it's worth at least going, there's grumbling out there. 42% said RVUs affected their salary to some degree, with 1/4 saying their salary was entirely based on RVU. If you are working with physicians whose entire salary is based on RVUs, you better believe there's going to be competition there. And more than 3/4 receive performance bonuses on RVU targets or benchmarks. That's very common in the contracts we see for APPs. Nearly 3/4 said they felt pressure to take on more patients. More than half said they occasionally or frequently felt compared by the employer to use higher level coding, which they thought interfered with ethical responsibility. And nearly 6 in 10 said the method for calculating the reimbursements was unfair, with almost half saying they weren't happy in how their workplace uses RVUs. Arden and I went to an MGMA conference incognito last year and sat at a table. I'll never forget this, where there was a woman who was the practice manager. So you were supposed to take the practice manager and the lead doc and go to this practice management meeting. And she was bragging how I think they got their APPs to sign agreements for RVUs with a high threshold and a conversion factor like in the teens. Was that right, Arden?
Yes, I think so.
And we just sat there and looked at each other, and she was bragging about how much money they were making, and I was just sitting there going, okay, it's because you need to supplement the salaries of your physicians off the back of your doctors, because the doctors in general do not tend to be happy, and yet there's only about 25 to 30% of physicians left in private practice to control their own destiny. The whole landscape's changing. And so here's just a few quotes that were taken from the survey. Assigning predetermined values for visits and procedures doesn't account for the intensity or the time spent. Putting the burden of generating RVUs on a doc is very unfair. Many patients don't show up. Okay. It could be better, it could be worse. It becomes a pure business transaction and a cold relationship that undermines trust and therefore compliance. So some interesting comments and grumblings about how it's changed the dynamics of being a healthcare provider as things have gotten tighter and harder to achieve the income you want. So here's some MGMA 24 survey data by specialty. You can see I've drawn a line at 3,000 RVUs with big arrows on the right. The top bar is related to physician-owned practices. The bottom is hospital-owned practices. And the APP is down here on the far right. So you can see in a physician practice, APPs are generating a lot more RVUs than if they're strictly hospital-based. But the most important thing I want you to see here is even maximizing their work in a private practice, the average really isn't much over 3,500, if that, per year. Okay? And then let's look at the surgical specialist topping between 8,000 and 10,000. So keep those numbers in mind as we move along. Who does the RVU model benefit in the OBGYN world? Well, we know the average or the median for RVUs is about 7,000. And the answer is it depends on how hard you want to work. So here's an example. Now, granted, this is from 2018, and I haven't been able to find in the public domain anything more current. But if you look at what's happening to RVUs, it's probably still just fine. and they're looking at the 10th percentile and the 90th percentile of RVU performance, an OBGYN that is a generalist, if he's not working very hard, he or she is not working very hard, it's only getting about 3,000 and topping out at about 11,500. With the highest, hardest working MFM getting around 16,000, 17,000 RVUs per year, which is insanely high and a very high amount of revenue generation. So let's take an example of a doc doing a laparoscopic hysterectomy. In 2018, the RVU was 13 point, the conversion factor no, the RVU was 13.36. The conversion factor was 35.99. So that would have generated $480 in 2018. And in 2025, with the new codes, it's generating $432 for Medicare. Can you see why the physicians are mad? Their jobs are, they're working harder and the dollars just keep decreasing year over year over year. So let's do 99385. An annual exam for an 18 to 39-year-old is 1.92 RVUs. So this is just playing around with numbers, okay? So an average range salary for an OBGYN around 7,000 RVUs, you need 33 RVUs a day, which would be 17 of those exams, 99385. But we know their schedule is far more blended, right? But that just sort of gives you an idea of the volume that has to be going through there if you're just doing routine exams, which they don't do. But let's flip it now to the midwife. First of all, is the volume of patients expected to be equivalent in the office in terms of the job that you're being offered? And what would happen if the midwife did all the normal exams to be able to free up the surgeon to do more complex, higher acuity, more surgeries, more procedures? Look at the RVUs they could be generating them with 17 exams a day. You understand that's not a lot of people if you can get that number in the schedule on a daily basis. So it sort of begs the question if RVU should be shared within the group to increase the overall practice volume and income, use the right provider in the right place at the right time and share the earnings. Sounds like a logical plan to me, but it's hard to get to this conversation. So what's a reasonable amount of RVUs for a midwife? Again, if we look at the OBGYN at about 6,500, 7,000, they need about 33 RVUs a day. What is the benchmark for midwives? Anybody have a guess before I move over there? Think there's any data out there on this? Oh, there isn't. Did I lose it? Oh, where'd it go? I lost it. Well, it may come up in a minute because I was doing some slide sorting. It's between 3,000 and 3,200 RVUs. That's our estimate of what an average full-time, full scope, high volume midwife could be doing. So what does RVU-based salary look like? You can see, I'm not going to go through all of this math, but a surgeon that's paid 60 per RVU, if they produce 6,000 RVUs a year, they'd be looking at about 360,000. A primary care physician who typically sits around 3,000 to 4,000. This is my daughter-in-law, averaging 46 RVUs per year, 184,000. And the midwife, an actual contract. Her salary was paid at $16 per RVU with a target of 5,000 per year, which would be 80,000. And there's no way she would even achieve that in the first place. So just some examples. And some confounding issues for midwives. Incident to billing is a big issue, and it's very complicated now that 25 has rolled around. The idea of shared visit billing, global billing. Are you billing by the rendering provider or the coding provider? And are you using numbers that are designed for FNPs versus midwives? And how can you extrapolate all of this to know that what's happening to you is fair This is a Sullivan-Cotter recent infographic from January that shows a whole lot of information that basically, from the purposes of me putting it up here, is for you to look right here on median wRVUs and median patient visits. Because in primary care, if an NP and a PA are doing around 4,000 RVUs, you know a midwife is not going to be achieving that. And so it's just important to understand that all of these numbers do have some correlations based on specialties, but there isn't anything out there for midwives other than trying to explain that much of our work is focused on global billing, which includes your in-hospital time as well, by and large, and not taking care of high acuity patients or doing procedures. And there it is. What's reasonable for midwives? Our best estimate when we're coaching and we're talking to hospitals who want to start midwife practices and are building RVUs in, or practices that are trying to get out of RVUs, seems like a reasonable estimate for a full-time midwife in a full scope practice in a hospital or a physician practice, not in community-based birth. This conversation shouldn't even exist in community-based birth. So let's look at some redacted contracts, the RVU carrot. I call the good, the bad, and the ugly. These contracts are from 24 and 25. If yours is up here, I apologize, but I don't think there's anything here that will disclose personal information. And this is one we just saw in the last 2 months. They were bragging in the contract about bonus compensation with a provider threshold at $66.50. Can we all just stop for a moment? Yeah, I see your eyes, Rachel. wRVUs above $66.50 would be paid at $25 per RVU. The provider must exceed the threshold annually to even qualify for bonus compensation. And we'll give you up to $38,000 annually. We're not going to give you the actual amount of what that might be, which would be far beyond $38,000 if you could even achieve it. And I think we deflated somebody's balloon when we wrote that review. But this was a new grad who had absolutely no idea and thought it was absolutely wonderful. Here's a straight 40-hour work week. Incentive bonus based on a benchmark of 1,900 in the first year of employment. All RVUs attained above the benchmark paid at 35 per RVU and a salary of 107. What do you think about that one?
Well, I think it depends how many office hours they're given. You know, if you're not going to be given office hours with GYN patients, you're
Yeah,
never going to make anything more than that.
that's
Or
our-
do you first assist? Do you,
It depends.
like, what is the practice structure?
Yeah. This one would require a lot of additional questions, as what we would say, to verify and clarify what exactly they're trying to offer you as an incentive bonus. Like I would say, can you help me understand how you came up with this benchmark? What is the average that the midwives currently have in this practice? What happens if you don't achieve 1,900? Are there any penalties or paybacks, which often you see later in the contract clauses? This one is hard to read, but I took a screenshot of it. So there's no definition of the FTE here. The annual salary is $130. It's a 5-year term and it's an FQHC. So the APP, so we already know they're not talking about CNMs. The APP shall receive a quarterly RVU, a bonus of $52 in excess of $567 per quarter, which is 1/4 of the annual threshold of 2266. The annual productivity bonus will be reconciled at the end of each calendar year. In the event the APP quarterly payments are in excess of the aggregate bonus amount, the APP will reimburse the hospital within 30 days of written notice and repayment amount due to the hospital. Really? What do you think about that? There's a problem there. First of all, a 5-year term is outrageous because once you sign the contract, you've agreed that that's going to be all the conditions of employment for 5 completed years, which means even though they say you could get a raise, they don't have to give you a raise at all. There was absolutely no definition of what full-time meant. And there's a payback clause here based on very extraneous statements they don't completely explain. So in this example, I would say, you're really enticing me with a high conversion factor and a pretty low benchmark of 2266. But can you give me a mathematical explanation of the last half of this paragraph? Because it really doesn't make a lot of sense to me. Unless you all think it makes sense to you, it made no sense to us. Here is a screenshot of a contract that used RVUs, but no conversion factor. They just made up the bonus. So if you produce more than 3,121 RVUs in the year, you got a whopping $8,000. And if you made between 2160 and 2279, they gave you 800. I mean, is this embarrassing or what? In addition to the fact that all bonuses are taxed separately. It's not a part of your salary. So $800 might end up being $400. It's really, really, I mean, this is so embarrassing. I can't even believe it's in a contract. Here's one. We're going to pay you $100,000 with an incentive of $1,350 for anything over $3,744. You see where these are all over the place? Here's one that is so complex and complicated in the exact codes that they use and that they will count towards your RVUs that by the time I got past line 3, I quit reading it. And it was just like, this is stupid. This is nonsensical. And I'm going to go back and talk to them if I were the midwife, put all that in a mathematical equation so I can understand exactly what you're talking about. Because it looks like, I mean, think about it. If you don't know what's going on and they've presented this as a beautiful bonus for you, wouldn't you think all of this is just great? Like there's something very positive that might come out of all these things they're going to code for you. Here's a tiered model, a productivity bonus based on $32 per RVU. Again, to me, this was a little complicated. I'm still not sure I can completely understand what it is they're trying to do to incentivize the provider based on the quarter. But we have a conversion factor here, but we don't have a benchmark of an RVU. And so there's just a lot of missing information in whatever they're trying to accomplish in that tiered model. Here's another tiered model. This was very recent, a couple weeks ago for years 1 and 2, and then 3 and 5. So they're going to start this midwife at 115,000 for RVUs up to and including 1783 with a conversion factor of $26 for everything over 1783, capped at $20,000. Why? Why aren't they capping it? If you did the work, you did the work, right? And then incentive table for years 3 through 5 is jumping up to 130,000 and your RVUs go up to 2132 with the same conversion factor of $26 and the same cap of 20,000. It's just like, help me understand how this makes any sense. So part of what I often will offer people is, look, just get rid of the RVUs and give me a better base. Then I don't have to worry about any taxes and I'm going to get paid more money for my base guaranteed salary. And I don't need to play your game. Give my RVUs to somebody else and then I won't make anybody mad. I'm being very nonchalant right now, but I'm also being very serious. So what should you do? You need to understand the language and ask questions. Is there a difference between the physician and APP, benchmark, and conversion factor? I can promise you 100% of the time the answer is yes. Fine. Please tell me what it is and see what they say. How often do you, as a rendering provider and hopefully billing provider, get to see your data? Monthly, quarterly, annually? I should have put in there never, which you're going to see in just a minute. What's the average RVU generated by the provider types in the group? And what happens if you don't meet the benchmark? Is it just an evaluation process like the Department of Defense that sits at a little less than 2,000? They're just looking at them to sort of see volume, productivity numbers, not dollar numbers. But a lot of the contracts have penalty paybacks. Another thing is get to know the office staff, get to know the coders, request that they do audits on your work, and ask for some monthly input on how you're doing so you can begin to understand what's happening. Understand the politics that play into productivity. How are the schedulers sending the types of patients to a specific provider? Whether it's the 10 midwives in the group or the 5 midwives and the 10 docs in the group. What are the politics that may be going on between the schedulers and their favorite obstetrician or favorite midwife? Use an RV calculator as a check and balance, and that's what a lot of the docs on Reddit are creating, these Excel sheets where they're tracking everything they're doing every day because they don't trust the billers and the coders. Track all the work hours, even hours that are non-billable. And that comes into another topic we talk about, which is leveraging your work, but your worth. But if you want to go to somebody and negotiate a higher salary or change in RVUs or whatever, you need to let them know the actual hours you're working that are non-billable, right? Beyond the full-time agreement. And consider midwives pool the RVUs rather than provider competition. There are other compensation models out there. This just came out from MGMA. And the other models that we often see in contracts include quality metrics, net collections, patient encounters, and gross billings. These are the big five in terms of either salary or salary plus bonus models. And you can see what's been happening to these. The net collections are actually going up, which happens to be our favorite model. And here it is. Gross billings or net collections is being more widely used, and it's actually based on cash received for services billed. In many practices, cash received is recorded as the actual revenue, so it's directly tied to the bottom line. So what we suggest is you determine what a fair percentage of net collections above expenses can be, and think of that as a bonus. What could you earn beyond your base? Lawyers do this in partnerships. So let's say after expenses, you've done this back of napkin pro forma and you know that you've generated $200,000. You've taken out all your costs, which in everything we did is about the lowest a full-time midwife is going to bring in. You usually bring in a whole lot more than that. Let's theoretically say you get 10% of the profit margin. That's a $20,000 bonus. And is much more fair and much more reasonably based on an ethical description of the work you do than an RVU. But you have to demonstrate your financial value in some kind of pro forma, because if you haven't fairly included the costs, all the costs, including overhead, then you're not going to convince anybody. But here is an example in an FNP contract that we reviewed. So most of ours are midwife contracts, but we have a fair amount of FNP, WHMP, and maybe 5 physician contracts we've done. This was an APC in internal medicine, and this is how they calculated as an example in the contract, which I thought was pretty sweet. They assumed that the actual revenue collected was $500,000. They took out wage expenses, taxes, and benefits. to leave a net revenue of 335. They took out 20% for overhead, which is not bad. That's a great number, which left a net profit of 268. So if that was a reality, that person at 10% of the net profit would get 26.8. I applauded this so much I couldn't believe it. It really is a way of taking out the entanglement of, if things are billed under your NPI, of taking out the entanglement of RVUs. So let's compare the two. Let's take an RVU model and a net collections model based on 8 births per month using 59400 with the RVUs attributed there. The total RVUs for 96 births would be 3511 with a conversion factor of 3241, and that would generate about $114,000 for the RVU model. In a net collections model, if you're assuming an average net collections of 3,000 times 96, that's 288 for the same. Now, Arden's probably sitting there going, this isn't exactly how it would be done, but I think it's sort of a quick and dirty way to show you that RVUs really don't tell the business anything about how much money they're collecting or how much potential profit is going on in the business. So let's talk about 2 midwife practices that sought help. The first one was a 3 CNM full scope practice employed by OBGYNs in the Midwest. And the second is 10 midwives employed in an MFM division in an academic teaching center in the Western region. Now, this might be a little hard to see, but this is one of the 3 midwives, and their reach was they had not gotten salary raises in like 10 years. They had no idea how much money they were bringing in. As you can see, this is to 2020. That the wRVUs were, where are they? Sitting around, I've lost them. There they are, around approaching 4,000. I mean, that's pretty amazing. And they were over 4,000 in 2019. But that's a lot of work going on for this midwife. And if you look at the charged amount, they were charging, about $850,000 when they were generating all those RVUs down there. And they really didn't have any sense of what was going on. And when you pair this up with percentiles, they were performing between the 75th and 90th percentile and being paid down around the 25th percentile. So we talked about, what do they want to do? And I convinced them that the net profit margin was the way to go, and they did, and they're very, very happy midwives today. So that's one example of how you can sort of try to project by month and by year what's happening with the RVUs and what's happening with the charged amounts and number of visits going on. This is the 10 midwives doing 95% OB services in an MFM division who had never seen their reports. They had no idea how much money they were generating. And when we asked them, they got everything we asked them to go retrieve, and their accounts receivable was $11 million. There was a union knocking on their door, and they decided, nope, we're going to stay here and ask for more salaries, and that's what they got. So here's some of the additional models. We often see these: quality and outcome indicators, the percent of readmission, access to care, discharge timing, attendance at meetings can be attributed, points, professional contributions. You often see these in academic midwife positions. Patient satisfaction can be generated on a quartile basis. If you get over 90% people love you in a quarter, you get a whopping $250. They're usually not very high paying. And then the encounters per day, which is a very common one for FQHCs, that is looking at particular targets, and then you're incentivized based on how many patients you see over that, typically per quarter. So there's a large variance in conversion factor as well as wRVU benchmarks and contracts. With and without an incentive, the defined work week is critical to understand, because if it says you will work a minimum of 40 hours a week and call, what does that mean? What is the average work week? And are you paid more for that? And it's likely you're not going to be generating more RVUs because of that. And there could be multiple incentive models within an offer if the RVU one doesn't seem like it's going to be that promising. So always understand the language and the metrics before you negotiate, because it's a little too late if you've already exposed your uncertainty and you're in the negotiation process. What's the process of scheduling new and established patients? That's a fair question. Is there adequate exam rooms for me? Do I have support staff? How many days am I going to be in the office? Will it instill competition between my peers and my colleagues? It's an important question. Are more complex visits and high volume expectations of your value in the setting? And then you need to ask yourself the question, like the midwife in Chicago, how hard and how do you want to work? And our lives change periodically. Our wants and needs change. So it's really a fair question. There's some resources I want you to know about. ACOG, if you're an educational affiliate, has their 25 changes to the Medicare physician fee schedule there, so you can see conversion factors and other new CPT codes. There's a free RVU calculator that you can see. I put in 99385 for one patient, and that was 1.92 RVUs. You can use this every single day and track your own RVUs if you want to. It's a pretty cool little device. wRVU is an initiative that tries to update every year. I did not see 24 and 25. It's a coding guide for the most common codes for women's health care. And I love this cartoon. Monitor your wants and needs. I've finally gotten to the stage in life where I can view myself by more than just my RVU. Isn't that a fascinating, likely never to happen, funny cartoon? So our sage advice, you have to understand numbers to negotiate your worth. Numbers from every perspective. And this area is clearly one of them. We want to let you know about our third annual conference in July back in Kansas City on the 24th and 25th. We've added a half a day to focus on the business of midwifery, and then all day Friday on clinical topics, and registration should open soon. We would love it if you would help share our work anywhere, your experience tonight or your experience with us over time. We do value what you have to say about us, and I'm going to ask you to join ACNM. We must have midwives engaging at the state level to advance this profession, because it is not going to advance at the federal level. And it's the states that really need to rally to try to make a lot of changes. And the hot one I'm on right now is hospital admit and discharge privileges. So I am going to go back to the open screen. And we have about 25 minutes for questions. And again, Arden's on here. So if I can't answer some of them, Arden, you better be awake. So thoughts, even if you don't have a question, how are you feeling? I know it takes about 5 minutes to warm up, so I'm going to give you that time. Did anybody learn anything new?
This is Nicole. I'm calling from New York. Well, I'm in from New York. I definitely learned a lot, because I always hear doctors talk about RVUs and like, you know, they want the delivery so they can get RVUs. And I didn't really understand it, but the breakdown that I learned tonight, I'm like, wow, very interesting on how individuals get paid and the difference.
Yeah.
Because
Yeah.
I thought it would have been beneficial because I work in a practice at a hospital. There's about 6 midwives, and we keep asking for like more money, but they keep saying that we're not bringing in enough. So then we like ask, well, what about if we get paid per RVUs? But I don't know if it's going to be worth it, you know?
Yeah. Yeah. You know, one of the interesting conversations might be, Nicole, in a just a very open way, if you feel comfortable talking to that doc, is, you know, would you mind sitting down with me sometime, you know, over a cup of coffee and just talking to me about your experience? And if you feel like there's competition with midwives being here, not judging anything, but just get them to talk.
Mm-hmm.
To see if you're coming from a curiosity. Are you a new midwife, Nicole?
No, I've been a midwife for some time now, over 10
Okay.
years.
But the RVU model is kind of new to you.
Yes.
Yeah. So it can even be poised in a way. I think sometimes we walk in different directions without realizing if we just stopped and talked to each other, we might be able to learn a little bit more.
Mm-hmm.
And is there a way, not that it would happen, but is there a way you could collegially approach whoever's making these decisions and
Mm-hmm.
figure out a way that it might be supportive of everybody in the work setting instead of competitive?
Yes.
One of the hospitals we worked with for a year lost their midwives, dropped a 1 from 5, building them back up. And in the end, the very first meeting we had, which was 1 year prior to the very last meeting we had 1 year later, what the physicians were most mad about and why they
Mm-hmm.
were treating the midwives so poorly was because they were changing to an RVU based model. And they were afraid the midwives were going to take all their RVUs away. Do you know what our answer was? Don't pay the midwives on RVUs. Give them a fair base salary and do whatever the heck you want to do with those RVUs. But don't assign them to the midwife who doesn't want to compete with you.
Yeah, I think we're we're paid off of a base salary, but not RVUs.
Yeah.
Yeah.
I'm kind of looking, yes, we are recording the webinar. I'm kind of looking at the questions over here. Shana, very true. Their productivity bonus was greater than their bonus awarded based on patient satisfaction. Yeah. So you can easily see how poorly that would influence patient care. Here's one from somebody who wants to know how you know your worth. We have a webinar on our YouTube channel and on our webpage. That's a talk I do for schools frequently, how to calculate your worth. And it's a whole nother conversation, but there's a pretty simple way to do it. If you can't find it, Chelsea, email me and I'll send you the PowerPoint. Other questions, observations? Yeah, Shana.
It's just so interesting to me that in OB that we're still holding on to this model when it just seems not to apply a lot, right? Because when you're on call, for example, you don't control who goes into labor. It's not like you can call up people and say, hey, come on in. I would love those RVUs from your birth. Like, that's not a thing. The same thing goes for every office that I've worked in. I don't control who's on my schedule. The front desk happens that when the patients call, they say, I need an appointment on this day. And the person who's working at the front desk just puts them on the schedule for whatever midwife has an opening.
Right.
In offices where you don't get to control those things, it
Right.
doesn't make sense to be judged based off of RVUs.
That's right.
It's different when you're a surgeon and you get to decide what your surgery schedule looks like. But when you're in OB, it's completely different.
Except for one thing, Shana, and I don't think it's just the ARRIVE trial. I think RVUs have a lot to do with it. Let's just induce everybody if you can get the room, go schedule the induction on their day that they're available, and they'll do their C-sections on the day that they're available so they can capture those.
But we don't even get to make those decisions independently, because if you're working at an institution, you won't get to put people on if the charge nurse says we don't have the rooms, or if there isn't the staffing. So again, it is not constraints that we can necessarily alter.
I think what's so fascinating, and I think I'm going to talk to my surgeon when I go back because my foot isn't completely healed yet. His wife is a neonatologist. He's an ortho specializing in feet and ankle. At the university where I had my surgery done, I think I don't know, you may know, Christy, I think they have over 30 operating rooms going on at the same time in general surgery. What would be really interesting is to know, as Arden said, how many of those are ortho over gynae? Because what's making more money, right? So how do they even slot those surgeries, which I think is what you may have come in, Shayna, after we talked about the research that the female urogynecologists are doing. Were you on when we talked about that?
I heard it. Yeah,
Okay.
not surprising, unfortunately.
I mean, it's just like it's a whole game out there. And how it is addressed is through a lot of angry people. And anger sort of goes downhill. So midwives are often caught in this trap. But yeah, I agree with you, Shayna. It's impossible to fix in the model of in the specialty area, especially.
Read once that OBGYNs tend to undervalue how much time they're doing on procedures, and that kind of has led to a decrease in what those RVUs are. I don't remember where I read that though.
Yeah, Arden, what's your thought about E&M and time-based coding and how that works?
Well, I think the time-based coding for E&Ms is a good thing, but that just it just increases your RVUs potentially in clinic. But the true issue is fixing the RVUs for all of the other things, all of the procedures. If they're going to, and the reimbursement for the procedures. And that's something that, Ginger, as we know, they're trying to do, but it's also 2 years out probably from happening. So how do you fix it now? How do you get better reimbursement now? That's the true key, not the RVUs, but the reimbursement.
I also, Arden, heard you speak in September, I think it was, and that fascinated me that there's only so many codes we can have, and they keep trying to add more codes, but we don't have enough. Like
Money.
it's not going to be able to money to pay it. That was fascinating to me, which doesn't fix the
And
problem.
like if they want to add 100 codes, for example, let's say ortho comes to the table with 100 codes and they only take 20 away. So much of the budget's going to go to the 80 codes they just brought. And then if ACOG comes to the table and they want to change maternity and add 10 codes hypothetically and only take away one code, well, then women's services are rated lower than anything else. So what happens when you add those 10 codes? Yes, it's great if it splits out the billing for different things and you get RVUs or you're paid more or you're paid for what you're actually doing. But is it really great if the reimbursement piece for each of those individual codes ends up being less than if you had billed globally? Such
Crazy.
a
Yeah.
And I read in the comments that you need, like, I don't remember, an MBA, I think it said, just to understand it. You need that, and I don't even know what else, like diagrams and
Patience.
patience. Yes.
Elena has a question. What can we do when C&Ms are all being paid the same base? Ouch, regardless of experience. And we're told the only way for the experienced midwives to be paid more is to implement RVUs. Well, that is, to me, the best strategy is to do a couple things. You need to gather information on your RVUs and your amount charged per year, like you saw on that one midwife, or the accounts received by that midwife that you saw. So get the data, the RVUs, the accounts receivable or accounts charged per midwife. And then figure out your costs. So malpractice, health benefits, all of that. You saw in that net collections example how that's done, overhead, and find out what the profit margin is that each midwife is generating and how much time you're actually working, your actual work hours, not that you're a 40-hour work week or that you're supposed to work 48 hours a week. Most of what we see, the average midwife works around 52. So that's adding in admin time, charting, phone calls, blah, blah, blah. Then you need to calculate your hourly salary based on the amount of hours you're actually working. And when you get all these numbers sort of put together and the midwives can cross compare, I think what's important to do is to have a really hard conversation within your group about how equity is defined among all of you. If equity includes years of experience, then it should be valued in some tiered fashion. And that kind of group proposal taken to an HR department is likely to be much more defensible and meaningful than if you all just go, get mad and say, it shouldn't be this way, somebody needs to fix it. You need to do a little bit of homework and come with possible solutions and not just frustration. So we've actually helped people do these things. It takes a little bit of time. Sometimes midwives don't want to get engaged in these kinds of conversations. They may be the major wage earner. They're afraid they're going to lose their job. They're going to close the practice. You have to be very sensitive about people involved in these kind of conversations. But at the same time, if you're using aggregate information or giving averages, you're not necessarily pointing fingers at anyone. It can be really the best strategy. And then look at comparative data. What's going on around the region? What's going on in Intermountain Health in Colorado that's different than Intermountain Health in Utah? And what's happening with CRNAs and FNPs and other people in the system? The more numbers you have, decisions are made more on numbers than patient satisfaction data. Decisions are made more on numbers than you have a low C-section rate. They probably wish you had a high C-section rate, so you would generate more money, or high admissions to the NICU, so they would generate more money, right? There are times when it's good, like leapfrog and some other variables that are databases out there, but you have to be able to use numbers to be able to have the language vocabulary that will make people want to listen. Does anybody have any thoughts about that? How do you promote transparency when midwives want to keep the information close? Well, I don't like that. But I also don't know that all of us should type in our salaries right now either, right? So the great state of Maryland, Shana, you can tell me if they've actually done this or not. I was out there helping with a retreat. Some of the midwives at Johns Hopkins who are on the doctoral faculty were going to use a REDCap salary survey, workforce studies survey. I don't know if they've done it yet. They have not done it yet, and captured data from over 500 midwives in the state. If every single state would just do one thing, just do that, and figure out what's going on with the midwives in your state, it could be very, very powerful data, because even though you didn't see it, it's not in this talk. When you look at the salary databases for midwives, none are reliable. None are reliable, just like there's no RVU data for midwives. None is reliable. But state-based information in a big state, or if you're in a small state like Oklahoma and you do a few surrounding neighboring states, could be pretty powerful, because a lot of those payers are paying within that state or region, right? And what the negotiated contract rates were could be different. It's hard to say.
Is there any, in your research on the RVUs, is there anything that delineates I guess it would be really the legality, um, or is it not designed on who performs the work, not just who bills it? Like, for example, we have a group practice where, it's doctors and midwives working alongside each other. The midwives are first call, we all work shifts. They have RVUs. We don't have RVUs, but they collect on our RVUs for what the services we perform.
Right. That happens a lot. I don't think, that's not a compliance issue. That's just a numbers issue.
Yeah.
It's just a numbers issue.
Yeah.
I
But
mean,
it's
that's
numbers
pretty
issue you wanna know.
standard.
Yeah. It's one of the problems. You can't track your RVUs if somebody else is accounting for them, even if you're not paid for them. Nobody's doing research, Shayna. Do you want to do that? No, we're not a big enough N, you guys. We're not a big enough N. There aren't that many of us in the nation. When you compare us to FNPs and PAs in particular, that's why it's so important we do this work ourselves, even if it's within a state. If we can't figure out how to do it on a national level, we could sure try to get better information on a state level. And if we had 10 states that could share their data, that would be really robust. It could give us some energy to move the dials a little bit. But I don't know of that movement yet, although Jennifer Jagger might be interested in some policy issues that can move that dial with some grant money.
That's right. Does anybody have grant money? No, I've been sitting here thinking, I'm in Portland, Oregon, and I'm a new member. I'm a member of a new union of about 700 advanced practice providers, which interestingly include midwives that work in the School of Medicine with physicians and residents, but also midwives that have a private practice in the independent practice in the School of Nursing. So there's so much variation in terms of how the different groups have historically been paid and valued and compensated in their workloads, and it's really complex, the work that the union is doing to try to I guess create workloads that are reasonable and compensation that values everyone's work. But like, as you very eloquently described, not everyone's work is valued the way we value things in America. And we're talking about how I think this is really great, because there are different ways to communicate your value, and I think we need to kind of blow it all up and push that those alternative to RVU models in the spaces where decisions are being made. But it's hard work. So I'm glad to see all these people here that want to do it.
Yeah, it's hard work.
And a student of mine from Georgetown and another student of mine from OHSU is here. So anyway, the future is coming and they are strong.
That's great. What I can just keep talking if there are any questions. So if you have a question, raise your hand or just jump in there. I don't want to keep you also if you want to go. I think what keeps us going, to be honest with you, is the midwives in distress. That's two groups. The new graduate who is absolutely clueless, who has a 30-page contract, and buried somewhere in it is this carrot. You saw the carrot graphic of this bonus compensation model, which sounds wonderful when you have $150,000 student loan debt. But somewhere in the clause are all the vaguenesses that come out about hours worked, how you're paid beyond base. Maybe there's paybacks related to X, Y, and Z, which are harsh penalties. And then we have established midwives, like the example I gave you of the 3 in the Midwest who I happen to know pretty well, who had never gotten a raise in 10 years and felt immobilized by the fact they didn't know what to do. And they just kept working because that's what we do. We bring our heart and we bring our talents and we think, well, if I'm not there, what will happen to my people? And yet they were suffering, and to a point where an opportunity happened when who they worked for got bought out by another entity. And I said, now's your time to jump. You have leverage. And that's what we have to understand. Somewhere in our experiences or in our knowledge that we gain is the word called leverage. And that's the key to negotiation. You have to be able to convey it in a lot of ways. And we don't teach that very well. I can say that as an educator for almost 15 years, and I've got some more educators here with me. We don't teach that very well, and it's a hard lesson to learn. If you walk away 15 years as a midwife with a $50,000 tail, you have to pay in 30 days to get your next job from Virginia to Colorado. I'll never forget that phone call. So anyway, the good news is now you know more. You too can go out and do research. We are going to put this on YouTube. But we're glad you came, and please share how important it is for people to know how to figure out your worth more than just RVUs, but this is very, very important to a lot of people. So any parting comments? Have you seen positive RVU contracts? Oh, Kelly. There was one that I said, maybe, right? There was one up there that was a possibility. Usually they're pretty slimy. Sorry. Even if it's not by what they're going to pay you, what happens to you by the conflict within the setting becomes very difficult to navigate. So thanks, Christy. It was nice to see all of you tonight, and feel free to send us questions if you have any anytime. Bye.